Good morning. Good morning. My name is Mark Baldessari, and I'm the President and CEO of the Public Policy Institute of California. Thank you all for joining us today. PPIC is pleased to present this timely program on Vaccinating California. This event is part of PPIC's 2021 Speaker Series on California's future. As a public charity, PPIC does not take or support positions on any ballot measure or legislation, nor does it support, endorse, or oppose any political parties or candidates for public office. We would like to thank the sponsors of this series for their underwriting support. These organizations are listed on your screen and on our website. In keeping with PPIC's transparency on funding, please note that one of today's speakers is from a foundation partner, but it had no bearing on the selection. This series is also funded by the PPIC Donor Circle and the PPIC Corporate Circle, individuals and organizations that provide PPIC with generous support. Please consider joining us as a sponsor or donor to make more public programs like today's possible. More information is available at ppic.org. And before we begin, if you have a question for the panelists, and we have three very distinguished panelists today, please send an email to the email address on the screen, including your name and organization, along with your question. I know we'll have time at the end of the program to devote to your questions, so please feel free to send questions. Now I would like to turn things over to our moderator, Melody Gutierrez, a staff writer for the Los Angeles Times. Melody, thank you so much for being with us here today.
Thank you, Mark. I appreciate it. And thank you for this important discussion. Wanted to thank the Public Policy Institute of California for this discussion. And as we enter today's discussion with this backdrop of sobering statistics about the toll of COVID-19 and what it has had on our state, our country, and the world, with more than 57,000 Californians dying from this deadly virus this year, it's time that we take a look at the vaccination and what it'll do for our state. We have learned that the state was ill-prepared for a pandemic, from the mask, ventilator, and other equipment shortages that dominated our early response to the missteps in California's testing capabilities. These challenges were largely understandable because they were unprepared. We knew that there were going to be missteps because nobody knew that N95 masks were going to be that critical. Our state had never needed to test that many people. But there was one area in which the state did anticipate that there would be a need for preparing, and that was for vaccinations. So now we're looking today at the challenges the state has faced in ensuring that all Californians have access today and in the future. We have had limited number of vaccinations. It has created a challenge in trying to distribute those and deciding who should be first in line. Today we have a distinguished panel that we will get into these questions and dive a little bit deeper. First, if you would like to submit those questions, I wanted to reiterate that if you have questions, we would like to get those at the end of this discussion. Send those into ppiceventquestions@gmail.com. And then now I'd like to introduce our panel. Their links are in their bios on the PPIC's event page. So in the interest of time, I will just read their general introductions. Dr. Nadine Burke Harris, Surgeon General of California. Dr. Sandra Hernández, President and CEO of the California Healthcare Foundation. And Assemblyman Jim Wood, Chair of the Assembly Health Committee. I'd like to start with a brief question, a very broad question on the status of COVID-19 infections and the vaccine distribution in California. What more needs to be done? And I'll start with you, Dr. Burke Harris, on this question.
Sure, yes, I'm happy. Thank you, Melody. I'm happy to join you. So what we know is that more than 5 million Californians are fully vaccinated, which is great news. And that we have over 13 million Californians who have received at least one dose. And so that's very positive. But we know that it doesn't tell the whole story. We know that the lowest socioeconomic quartile in California experiences almost 40% of disease and death from COVID-19, and yet they have received less than their population share of vaccines, right? That's something that absolutely needs to change. And that is why the governor recently in the state took the position of allocating 40% of vaccine to that lowest HPI quartile so that we can target vaccine proportionately with burden of disease. So I think that overall, we see that it's quite promising in terms of California's rate of vaccination. We're improving our overall vaccination picture, but we know we have a lot of work to do, and particularly for our most vulnerable.
Thank you. Dr. Hernandez?
Hey, good morning, Melody. Nice to be with you. Yeah, I think it's important first just to step back and recognize that even knowing we were going to need to prepare for vaccinations for, arguably 40 million Californians eventually, it is still an unprecedented scale of effort that we're trying to stand up in the middle of a pandemic. And I just think that's just an important backdrop for the entire conversation. To build very briefly on Dr. Burke's comments, we do have significant resources in the state in the form of our community health centers who are really just doing an extraordinary job, both in educating, messaging, and then really outreach to the very population that our Surgeon General referenced. And that involves kind of reducing all of the barriers you can imagine that low-income folks and people of color have in getting access, whether that's broadband or transportation or going to where they work to be able to deliver vaccines. That's really the phase that we're in at this point in the state. And I think, we have the resources in terms of the capability through our community health centers that both the federal government and increasingly the state is beginning to recognize and directly resource.
Assemblymember Wood?
Yes, first of all, thank you for the opportunity to be here and to not duplicate anything that's been said. One of the things that I would probably add to that, I think I just read this morning, we're close to 15 million vaccines administered in the state. That's a pretty amazing number. I think I will just reflect back that I don't think we were quite prepared for as early as the vaccine came. And I think that has probably hampered us a little bit. I think the CDC's guidelines for how to begin vaccinations didn't even come out until late October. And so it was really hard for counties to really scale up. But now we're seeing, not just the clinics, and I think that that's a really important component of this for our harder to reach communities. But now we're seeing more outreach through community-based organizations. So those organizations that people trust in their communities to help identify people who are at risk and get them closer to getting a vaccine and hopefully get those vaccines in arms.
Thank you. Dr. Burke Harris, you're on the Vaccine Advisory Committee, and I wanted to ask you specifically about some of the priority groups right now. There's a lot of people prioritized. Are the right people being prioritized for the limited amount of doses to ensure that the people who need it the most are receiving it?
That's a great question. And I will tell you that our prioritization strategy for the state of California is really based on a couple of factors. It's based on risk, it's based on equity, in part it's based on occupational exposure. And as you know, we've had to make some shifts and some course corrections in our allocation strategy, but we really do believe that we are prioritizing those who are most vulnerable and who have the greatest risk and the greatest exposure. So I would say, so as you know, we just recently announced prioritization for individuals who are, for example, in congregate settings, right? We additionally have been working through the process of the Community Vaccine Advisory Committee to really lift up the voices of vulnerable communities and have that important conversation about not only who to prioritize, but how to reach vulnerable communities as well. So that's part of the reason why you see equity as being the North Star in California's vaccine allocation strategy.
Dr. Hernandez, could you speak a little bit about the equity equation and how you're seeing it play out, and whether the right people are being prioritized right now for that limited number of doses?
Yeah, Melody, I think a couple things. Supply right now is relatively constrained. And what we're trying to do, and the state is trying to do, and really all of the partners of the state, county, clinics, health systems, it really is an all hands on deck effort. Keep in mind that these vaccines also have their own challenges as it relates to storage. So, the Pfizer vaccine requires deep storage. Not everybody has the capability to do that. The Johnson & Johnson allocation of vaccines with a single dose is really a significant lift for the state, in the sense that it is much easier to get a vaccine that only requires a single dose to places in the state that are harder to reach if you need deep freeze, for example, for Pfizer. So there are some unique qualities around these vaccines that also weigh into how do you get into a more equitable distribution. And I think you have to also understand just the epidemiology of the disease. It is a much more lethal disease in older age groups. And so to prioritize 65 and older really was the right thing to do all across the state. However, many of our communities of color are relatively younger. And so you have these competing efforts around trying to decrease mortality. So get a vaccine to people who are over the age of 65, and then just recognize we have a large chronic disease burden in the state. And people who are, 62 with diabetes and hypertension might be at more risk than people who are 66 and don't have those. So the equity equation in this is complicated and very important to pay attention to. And so I think what we are doing in the state is trying to pivot both what we have in supply and type of vaccine, recognizing who we are as a state, and our essential workers who really worked throughout this pandemic. And, they've also been prioritized within this mix, rightly so. It helps keep the economy going. So all of those components have made what could seem like a somewhat chaotic, I would argue it's complex, and really trying to meet all of those goals. You're trying to obviously decrease mortality. And you also need to just recognize we have a lot of chronic disease burden in our low income and people of color communities. And how do we reach them effectively? And I do think the J&J vaccine was a big lift. Direct distributions to clinics has helped significantly in that space.
Assemblyman, what are you hearing from your constituents? What are the calls that you get in your office and hear from your community? For my communities, it's interesting. I represent 5 different counties, and they tend to be 4 of them are very rural, and so a lot of it is around if we could just get the doses, we can get them into arms, and that's a big challenge. And so I think the biggest concern has been around equity, and I think that getting to those populations, those groups of people that are the most susceptible, the most at risk, has continued to be a challenge. I have been a big proponent about, how do we get into the hot spots? How do we identify those areas and really get in and focus on them? And I agree that the initial approach of getting to older people, getting to people in skilled nursing facilities was absolutely critical. But when you look at people who are poorer, they often tend to live in multi-generational households. So just getting the vaccine to the elder in that home doesn't protect the entire home. So I've been an advocate for, we need to vaccinate everybody in those homes where the highest disease rates are, and do that as quickly as we can. And I'll be honest, we haven't been able to do that. It's difficult, and we haven't been able to do it. And I hope that as we get more vaccine, that we can really do it that way, because I believe that we can really slow this down by getting more of that, we'll call it pod immunity, within larger households that are all living together. And that's been a real challenge for us. Dr. Burke Harris, was that part of the initial discussion to look at pod immunity type of networking, looking at a household and ensuring that those are protected around that, sort of like what Assemblyman Wood has just said?
Yeah, so yes, absolutely. That was part of the discussion. And I think that the thing to recognize and to keep in mind is that really surfaces the very challenge that we have. If there was an unlimited supply of vaccine, right? Certainly, that's exactly what we want to do. That is that's a great strategy. And I think that, of course, the challenge that we were facing was that given that we had such a constrained supply, and looking at the risk, as Dr. Hernández talked about, which populations were at highest risk. And, when we look at, for example, what the difference in mortality is for our seniors, for those who are at 85 and older, the risk is, 620 times the risk of death. When we look at those 75, 65, we're still going to a range between, 90 down to 90 times as great the risk of death. And so those were some of the considerations that we're looking at. We're looking at 3 times the risk of death compared to 90 times the risk of death, and trying to figure out, okay, so how do we save the most lives as quickly as possible, recognizing, and I think this is really important, recognizing that more vaccine is coming, right? So we're just, we've been asking the public to hold tight. We've heard from President Biden that there's an anticipation that we are going to have a significantly increased supply, hopefully in the coming months. And so that is one of the pieces. And as we open up eligibility, as greater supply comes into the state, we will continue to have equity at the forefront. So any additional decisions that will be made in terms of looking at our eligibility here in California, I want to assure folks that will be made with those equity, with that value of equity as being front and center in that discussion. But you're absolutely right in getting to some of the difficult conversations that we had to have around how are we allocating vaccine.
Do you anticipate, this is for the entire panel or whoever feels like they can answer this, do you anticipate there being another challenge on the horizon when it's not scarcity driving the conversation, when there are enough vaccines for every adult, as President Biden has said are on the way, and these are in the coming months? Do you anticipate there being a large challenge in California of actually getting those out once there are enough?
Yeah, Melody, I'll jump in here and say a couple things. If you look at survey data, Kaiser, Pew, et cetera, it looks like there might be 25% of the population, some surveys maybe as high as 30, who are what we would describe as hesitant. That doesn't mean they're unwilling to take a vaccine. That just means they're hesitant. And there's a heterogeneous group of reasons for that. So you can't really make any particular assumptions about that group. What you really need to do is get into that community, understand what the concerns are, hear them, address them directly. There are a lot of folks that don't want to be at the front of the line. And one of the things I think we'll see with time, and this is actually beginning to show a little bit of this already, that as we get through the scarcity area and people have done fine with these vaccines, we'll see more of this hesitancy group being willing to get a vaccine. But that part will be harder. It will be micro, local, hyper local. And I'm not talking about anti-vaxxers. That's probably a persistent group that we will never, conspiracy theorists, et cetera. But I think it will be harder. This is true as we've seen in flu vaccine. By the way, we have a enormous challenge to get our children vaccine who've been uniformly not vaccinated as we've been in shelter in place because we haven't been interfacing with the healthcare system for those kids. So there's a lot of opportunity to do education around vaccination, kids, family members, parents, but we're going to have to really work very hard. And I do think, by the way, that curve is the next curve ahead of us in the pandemic, is to really whittle that hesitancy group down, really understand what the concerns are, try to hear them, appreciate them, and work through them and encourage folks to go ahead and get on board.
I know Governor Newsom has announced a $40 million media campaign to try to address some of the hesitancy issues. I'm curious what you're seeing, Dr. Burke Harris, in terms of the hesitancy around vaccines. Do you anticipate this being a large group? I know Dr. Hernández talked about some of the studies saying, up to 30% could be hesitant. How does the state get into the communities where they're seeing the hardest hit misinformation campaigns to address this issue?
Yes. So we've partnered with researchers to better understand what is what are the factors that inform the confidence of different groups of people in taking the vaccine. One of the things that affects vaccine confidence is the efficacy rate. We have been incredibly fortunate to have very, very highly effective vaccines. So if you have a vaccine and it's 55% effective, you see that the vaccine confidence goes down. But we have vaccines. All of the vaccines that have been approved, all three, are 100% effective at preventing death, 100% effective at preventing hospitalizations. That's a big deal, right? So we have very effective vaccines. And then we look, and in different communities, what we hear, as Dr. Hernández pointed out, it's very accurate, that it's really a heterogeneous group. And some folks are wait and see, some folks want to understand more about the science, all of these different pieces. And our approach to addressing that is several-fold. Number one, by partnering with trusted messengers, especially in vulnerable communities, working with trusted messengers and trusted providers. And actually, I don't know if you've had a chance to see it, but if you haven't, you should absolutely check it out. The state's Vaccinate All 58 campaign. We just released a new public education campaign, and it's really targeted towards that. It's around, if you have questions, if you have concerns, that's okay. Whatever it takes to get you there, right? It's fine to ask your friends or your family members. It's fine to talk to a trusted provider. Any of that process of exploring is normal and natural. It's okay. And the important thing is that our vaccines are safe and effective, and you can learn more. And whatever it takes to get you to vaccination, that journey is fine. It's a really, really powerful campaign. But the other piece of it is really addressing the misinformation and disinformation that's out there. So I've heard the false statement that vaccination is going to affect your fertility. Like that's untrue. There's false statements suggesting lots of different types of side effects, problems, challenges. And the way that we respond to that is really by countering with accurate information about what to expect in terms of side effects, what happens, what is the process, for example. We know that the CDC and the FDA actually track all of the side effects that are reported from the vaccine. And they do this through a process called the Vaccine Adverse Event Reporting System. So if there's anyone who believes that they had a challenge or a health concern that arose around the time of their vaccination, right? It's investigated, and healthcare professionals, doctors, public health experts go and investigate and understand, is this actually associated with the vaccine or is it not, right? Because when we are vaccinating. I mean, here in California, when we're looking at 15 million folks, almost 15 million folks who have been vaccinated. Thank you, Dr. Wood, for correcting me. I think I said 13 million, but it is 15 million vaccinated, right? You can imagine that tracking carefully which of the healthcare events that happen in the time of vaccination and whether or not they're related to the vaccine is very, very important. And I think that the public has seen that, for example, when there was a question down at Dodger Stadium when we had several folks who had swelling or urticaria after vaccination, we stopped vaccination. We did an investigation. We had medical and public health experts come in. We looked at the batches, right? And then we determined that it was safe to resume vaccination. And that is what we are doing across the state of California because safety is our #1 priority.
Thank you. And Assemblyman Wood, you obviously have seen in the legislature over the last couple of years an increasing tide of interruptions of demonstrations inside the Capitol. And I'm curious if you feel that the current climate is any different. Do you feel, the vaccination questions that happened around school required vaccination bills is the same as what you're seeing now in the legislature with interruptions and some of the calls that are into hearings?
We're not seeing as many right now as we have in the past. I think the level of the vitriol is when we do get those calls is very, very high. But we're not seeing as much right now, and we may. I think part of it's been limited by the fact that it's harder to be in the audience in the Capitol. It's certainly not harder to make phone calls, but I think as more and more vaccine becomes available, as we approach that herd immunity, we may hear more, and that remains to be seen. If it's okay, I want to piggyback on something about how do we get past some of the hesitancy and I think of my own district. I represent more than 30 Native American tribal communities. And so there is hesitancy within many of those tribes, and with good reason. There's things that have happened to tribes over our history in California that have given them, give them reason to be cautious. But getting in, there's so many different communities of people out there. Getting to the trusted messengers who can then give comfort and faith in the product to people is difficult in more remote areas. And so it has to be a really concerted effort, and I'm pleased the administration is working closely with us on our tribal communities in particular.
Yeah, Melody, you raised something that worth probably mentioning, and that is this sort of philosophical, perhaps even policy question about mandating vaccines. Mm-hmm. And my sense is that in the environment in which we are in, education, trusted messengers is going to be much more effective than absolutely requiring people get vaccines. And there's some survey data that would suggest that is the case. And so there are certainly places where that will be appropriate, legitimate, but as an overall approach, we should really be working on, messengers. CHCF did a PSA with Black physicians called Among Us, About Us. Really talking specifically to the experiences of the Black community. We're doing the same thing with the Latinx community because these histories are different, as Assemblyman Wood mentions. And I think we have to be really nuanced with these messages as we think both about what we're saying, how do we address concerns, historical trust going forward. And it's just hard to mandate trust, right? So I think us really targeting these communities who have a lot of historical reasons maybe not to trust our healthcare system is really the best way to get us to herd immunity.
Is the state positioned now to be in those communities to have those trusted messengers allied with the state? I mean, how do you assess the state's ability to get into those hard to reach places right now?
So the state's approach to it is really to support the capacity that already exists within our communities. So, for example, between the state and Public Health Institute, in partnership, we have funded more than $52 million to serve, to fund over 300 community-based organizations. And the goal there is that these are organizations that are doing the very, very hard work on the ground every day, who have had long histories of relationships and partnerships with vulnerable communities. And in fact, much of what we did was we took advantage of the infrastructure that was already established through the census process, where we worked with CBO partners through the census to help to count some of our hard to reach, hard to count populations. And it really is leveraging those long-standing relationships. And so what we wanted to do as a state is just put wind behind the sails of our community partners who are already doing excellent work to increase their capacity and to make sure that they have the tools, the resources, everything that they need to be able to support folks to get the information and the resources to be able to get vaccinated.
I wanted to remind those who are watching right now that if you have questions, we will get to those in the last part of this event, and you can send those into PPIC event questions@gmail.com. Send those in now and we can go through those at the time and bring those up. We'll have some time at the end of this. I did want to ask about the changes in vaccine delivery in the state. With the state moving to a statewide vaccine network, this has been pretty controversial in counties that said that they had the ability to do this already, and we're not very happy about this change. It looks like the many counties are starting to sign on to this change. Wanted to ask you each about this delivery system from your perspective. Was it needed, and will it help? Starting with you, Dr. Wood.
Yeah, I'm happy to take that. You know, at first, I think when I heard about it, I was a little puzzled and concerned. But there was a group of us who are meeting regularly with the administration, and we had a meeting with the people at Blue Shield to understand what it is they're going to do. I think once I understood that this is really about data and moving vaccines to places where it is needed the most. And that data has been one of our weakest points here in California. And it's very difficult. I could ask CDPH, I can ask DHCS, can you give me information about this? And it's really hard with our systems. They're not as well coordinated as they should be. So this idea of creating a separate data system to track vaccines and who's giving it and when they're being given is critical to actually being very efficient here. So once I think counties began to understand that this wasn't some entity coming to take over, it's really meant to be, in many ways, a data backbone to be able to support the great work that counties are doing. And now they're relying on the work that the counties are doing on the ground with those community-based organizations, the FQHCs, and really beginning to coordinate. So I think that's why you're seeing now more counties come aboard. I'm not surprised that we went with an MOU, memorandums of understanding. Counties do that much more regularly than sign contracts. And so I'm not saying it was a wrong approach to go with contracts, but it's understandable the way counties operate, that an MOU process, and it's taken a little bit longer. But in those counties where it's up and running, it's working, and it's not without the stops and starts. But it all goes back to that pure positive data stream that we've been lacking. And now that we are starting to get that, you're going to get more predictability in how the doses go out. And I think that's going to really show dividends here fairly quickly.
Dr. Hernandez, what are your thoughts on this change?
Yeah, I agree with everything Assemblymember Wood said. I might add two additional things. Again, the vaccines, at least the first two, Pfizer and Moderna, required 2 doses, right? So it's one thing to get people in, get their first dose, but then you actually have to schedule them if it's Pfizer for a 21-day second dose, if it's Moderna for a 28-day second dose. And the scheduling of that and the collection of data from that is hugely important, because as our Surgeon General mentioned, you really do want to make decisions based on the best data that you have. And so being able to collect the race ethnicity data, the age data, the risk factor data is all important for us to understand where we're reaching and where we're not. And, you know, it's astounding that we spend 18% of our GDP in healthcare, and our infrastructure for data and data exchange and data collection is Neanderthal. Really, it is. It is, and the legislature is working on this. So I think that was an attempt to try to remedy the complexity of 2 doses and scheduling for that, trying to understand what doses came in, where they were, where they needed to be to get a second dose. Those were all sort of the problems that I think the TPA was aimed at. And then the last thing I would say is, look, our counties have, since the beginning of the pandemic, been running at 100 miles an hour to do testing and contact tracing, basic public health infrastructure tools to control disease outbreaks. And they've been doing that with very shoestring capabilities. We have a very inadequate workforce for public health. When the pandemic broke out, there was a survey by California Department of Public Health just to see what counties had anybody who knew how to do contact tracing. The majority of the counties in the state did not have anybody to do that. So the counties have been working overtime on testing capability and getting testing done and doing contact tracing and helping people with quarantine and doing our turnkey housing for people that were unsheltered. So I think helping the infrastructure of data and scheduling and deployment of vaccine was a very reasonable goal for the state to try to address. And recognizing again that, yes, we need all of our public health departments to be part of this, but the delivery system of this needs to be, as we said, in places that are much more decentralized. And so tracking those vaccines to get there and making sure that people have the doses they needed for the second dose on 28 days after you vaccinated hundreds of people on day X. So long-winded answer, but I think it was a legitimate problem to try to solve.
Dr. Burke Harris, did you feel that Blue Shield was the right choice to help with these problems? And also, how bad was the data that you were seeing? And at what point did you realize it was just not what the state needed in order to have a full assessment of what was happening in the state?
Yeah, so a couple of things. Number one, I think that Blue Shield was a very strong choice. And I want to highlight that Blue Shield is doing this they're not making any money off of it, right? They're doing it in partnership with the state, and there's no profit to them at all. But I want to really reinforce what Assemblymember Wood and Dr. Hernández said in terms of the scope of the challenge, in terms of, we are incredibly grateful for the amazing hard work of our local health jurisdictions. They have not only been doing testing and contact tracing and making sure everyone has PPE and doing all of these things on the local level. But in addition, you'll recall that when vaccines arrived in the state, it was just as our surge was peaking in the state of California. So when we're talking about December into January was the darkest hour of the COVID pandemic. And I'll just, be a little unguarded here in saying it was unbelievable. I will tell you that people were literally working around the clock, and the incredible effort from our local health jurisdictions was just beyond. I mean, we were at the point where, we were standing up alternative care sites, right? Because to preserve our hospital infrastructure, our ICU capacity, all of those pieces. And that was the moment when vaccine arrived, which we're incredibly grateful for, but it was also a very, very challenging time in the course of the pandemic in California. And so when we talk about the need for better tracking of data, that certainly was there. And when we talk about the need for undergirding our vaccine allocation and deployment strategy in California with a stronger infrastructure, like we had 58 local health jurisdictions or 61 local health jurisdictions doing their amazing work, and also we were hearing from the public that it felt confusing. That in one county you could go and get a vaccine and certain folks could go, and in another county you couldn't get vaccinated. So that was really challenging, and really thinking about how did we, so in partnering with Blue Shield to do this third-party administrator agreement, a big part of it was really how do we support this system that is already in place? How do we support what's already there, what's already working well, and strengthen the pieces that need strengthening? And I think that's absolutely what we are achieving through this TPA. I think that, of course, in the process of getting everything up and on board, and there's going to be some negotiations between local health jurisdiction and the TPA, and I think that's normal. And as we see, more and more counties are coming on board, and I think that ultimately is going to be a great outcome for California.
Do you think that in terms of the for the counties that were doing well, that it feels like reinventing the wheel to them, that they had already created these partnerships, they had the infrastructure, they had invested in this infrastructure, and now they're being asked to change what they feel is working in those counties? Do you have any response to those who are still kind of pushing back and saying, this isn't needed here? You had mentioned just sort of the difference between if you live on the border of a county, that you can go into one and there's a difference. Do you think that that's a strong enough argument to say there needs to be unilateral vaccine distribution versus in a county that says they've done well and they can prove they've done well, that they need to be part of this?
So I think that was the perception initially, and my experience in talking with counties and in talking with the TPA is that many counties perhaps had that perception, and then when they got a chance to get into it and sit at the table and walk through what the TPA is asking them to do, what the TPA is going to provide, how the system all works together, I think a lot of that got clarified, and it wasn't nearly as onerous as many counties thought it was going to be.
And I would like to switch over to some of the listener questions. One of the first ones that is obviously going to pop up is something that a lot of parents have thought about is, when will these vaccines be available for children? I'm curious who, any of you three, if you've had discussions on this, if you'd like to weigh in, when will they be available? And I know a lot of the other questions is, do you anticipate that those will be required to attend school at some point?
Well, I'll just say what I know about the availability or when they'll be available. I know that there are ongoing research about efficacy and safety for children, and so it's going to be a while, I think, before that becomes apparent. And I don't know, at this point, will that be a required vaccination? It's hard to say, but I think that population 16 and under, it's going to be a while before you start to see more vaccines, and that's we're going to rely heavily, obviously, on CDC for that information, and but the work is ongoing by all the major manufacturers of vaccines.
Yeah, the thing that I will add to that is that, as Assemblymember Wood mentioned, those clinical trials are currently underway, enrolling children to assess the safety and efficacy of the vaccine. Now, one of the things that's challenging about doing clinical trials in children as opposed to adults with COVID is we know that the rate of kids developing COVID is a bit lower. And the way that it works is that when you do a clinical trial, you're driving towards the outcome that you have to get to is X many people in the placebo group that get the vaccine, right? And then X many people in the placebo group that become ill, right? And so you're looking to know whether or not the vaccine is in fact effective. And so when we're looking at the current rate of COVID among children who become ill and particularly become symptomatic, we recognize that doing the same clinical trial, but in just looking at the epidemiology in children rather than adults, ends up taking a longer period of time because it takes longer to get as many symptomatic kids. And so these are some of the questions that some of the investigators are looking at, is trying to understand how do we answer these questions of efficacy in the pediatric population in the given period of time, right?
Yeah, I would maybe just add two other dimensions to this. One is that one of the things we know is that the COVID-19 virus, the coronavirus, has a receptor that allows it to get into our airways. And in children under the age of 12, they just have much fewer of these receptors. So to Dr. Burke's point, it will be much longer and much harder to show that a particular vaccine is efficacious in preventing something that is very unique and rare to occur. And I think that's an important point. So the question about safety of these vaccines, certainly the messenger RNA vaccines, the Pfizer, Moderna vaccines, those are pretty easy to manufacture and are incredibly safe RNA vaccines. And so I think this will not be so much about safety as it will be about efficacy as we get into these clinical trials with younger children.
With few infections for children, do you anticipate if enough adults are vaccinated that the need for children to be vaccinated will decrease?
No, we still need to vaccinate kids when we have a safe and effective vaccine.
And do you anticipate that being the difficulties of developing that? Do you anticipate that being a year, years? Is there any kind of time frame that you guys can provide?
I could not tell you. I don't know if anyone else has more information than I do, but I couldn't tell you.
And then moving on to another question. At a legislative hearing, there was the Yolo County health officer, as well as a health officer in Los Angeles, had talked a lot about the data issues in underreporting the number of vaccination given. Could you talk about whether these data issues are solved now? Are these still an issue? What are you hearing from the numbers and the accuracy of the data we have now? Assemblymember Wood, do you have any insight there?
I can make some general comments. I think that our data challenges are going to be, you're going to see a pretty rapid improvement, and I think we have to attribute a lot of that to the TPA, quite frankly. And it has been a challenge, and part of it is a lag. The way things get reported go different ways into different kinds of databases, and so having a single dedicated database for these kinds of things makes a huge difference. And so we're already seeing better data being reported with those counties that are working with the TPA. We're seeing better data already, and I think that will only continue to improve. And it's really important that we have this a system that gives us good data, because we don't know how long the immunity from the vaccine is going to last. And so we're going to need to know, when did someone get a vaccine? how long, did they have any side effects, and so on. We're going to need that data going forward as we get into the fall and winter, if we start to see an uptick in cases again. I go back. I'm a data geek. The more the better. We really need. It needs to be really foundational for our public health infrastructure.
I think I'm seeing a theme in some of the questions that are coming in right now from viewers, and that is about the frustration with getting appointments, the frustration about what feels like an ever-changing priority list, and the frustration of not knowing when it will be their turn. Could you each speak about this point? Did the state give clear enough guidance on when it will be people's turn versus going on to a system and logging in and getting a kind of nondescript answer? And what can the state do to make it clear, when you can get an appointment and how long you need to wait? Dr. Burke Harris, I know this is something you're very much.
Yeah, that's a great question. And one of the things that I want to do is highlight the difference between eligibility and availability, right? So as the state rolls out the eligibility criteria, that really talks about who is able to make an appointment to get a vaccine. But the question, as we've talked about, and this is a real, this has been the challenge, is that we have been in constrained supply. California has the capacity to vaccinate. Right now we're vaccinating just over 200,000 folks a day. We have the capacity to do much more than that. But as we've heard, over and over again, we are constrained by supply. And we hear from the public the frustrations that how frustrating that feels to be constrained, right? How frustrating it feels to say, wait, I'm eligible, but when I go on, there's no available appointments in my area, right? And so part of what we've done to address that is for a while, we were facing the situation where, again, folks would say, oh, I hear the state eligibility is what it is, but if one county versus another county, it feels like they're implementing that in a different way. Right. And so coming with the state moving to the My Turn system, right, creating and rolling out the My Turn system. So there is one place where folks can go, put in their information, find out if they're eligible. If they are eligible, find out when they can get an appointment. If an appointment's not immediately available, to put their information in so that they will be notified when an appointment becomes available, right? And if they're not eligible at this time, again, they can put their information in so that they can be notified when they become eligible. So all of those things are steps that the state has taken to be able to address that. And again, the big thing that I want to highlight for folks is that although supply is constrained right now, right, we anticipate that what we're hearing from the Biden administration is that in April and in May, we will see increases in our vaccine supply, and that will alleviate some of that frustration that people are feeling.
I'd like to add something else into this, and I absolutely appreciate and agree with everything you've said, Dr. Burke. And I think it is really challenging for people. One of the people who works in our office here in the Capitol has almost made it her mission to help people find appointments in her off hours. And so she goes out and scours websites and places and helps connect people, and has been very successful at it. But I guess goes back to we don't have a great system that's cohesive. Wouldn't it be great if you could call your doctor and your doctor would be able to look on a website and say, well, there's appointments available here, here, and here. Where would you like to go? Instead of having to try to reach out to each one of those independent sites to be able to see if there are appointments available. And that's one of the things I'm just going to put in a plug for. One of the things I'm working on this year is that people think their health information is much more cohesive than it is, but it's not. And that kind of lack of ability to get to some of those things makes it really difficult for us. And I just think that we'd be in much better shape if we had some sort of centralized way to find those appointments quickly and get people to them. And there are appointments. My scheduler, God bless her, has been working on this. She sent me a link last night. She said, "Go on here, pretend you want to get a vaccination," and I did. And I found I could get a vaccination tomorrow. So they're out there. It's just hard for people to find it. And as we get more vaccine, I think a lot of those challenges go away, quite frankly.
Coming back, Melody, just to we started the conversation talking about equity. And I think once supply is not the constraint or the bottleneck, the most equitable way to get access to the folks that have had the most trouble because they don't have internet, because they don't have broadband, because they don't have transportation, is really not to do an appointment system at all and really allow people to walk into, whether it's their healthcare provider, whether it's Kaiser, whether it's UC, whether it's Dignity, whether it's CVS, whether it's Walgreens. The ultimate goal, again, when supply is not constrained, call that, 30 days, 45 days. If we're really going to take an equitable approach to this, we won't be talking about appointments at all. We'll be talking about no wrong door to get a vaccine. And that really should be our long-term goal.
One of the reader questions.
One thing to that, because I think it is important. I mean, especially with harder to reach communities and people that may be working 2 or 3 jobs, we've got to have clinics that are available at a time that's convenient for them. We can't run a clinic till 4 o'clock in the afternoon and call it good, because a lot of people who live in poor neighborhoods maybe have difficulty with transportation. It's not easy for them to get there. We need to either get to them, ideally, right into the neighborhood if possible, or make it easy, because we can't just shut a clinic down at 4 o'clock in the afternoon because the employees need to go home. No, we need to figure out, better scheduling there, because the harder to reach communities are going to have a harder time getting to these clinics when they're available.
And that's actually, I think both of those points, I just want to speak to that very quickly, is both of those points are things that the TPA is including in our equity strategy. So right now for our lowest quartile clinics, in addition to looking at the hours and the accessibility and all of those pieces, one of the important pieces is ensuring that walk-in appointments are available, particularly for our vulnerable communities. So these things are happening. I just wanted to highlight that.
Because we are limited on time here, I did want to look ahead and ask each of you what you are looking forward to when vaccines are readily available, when yourselves are vaccinated, when life returns to normal. What is it that you see changing, and how fast do you anticipate those changes? Will society return to what we used to know?
Okay, I'll start. Yes, I want to be able to go out to a restaurant. I want to be able to go, to taste wine somewhere, or have a drink at a brewery, or go to a park. I want to go to a baseball game. I mean, yeah, I think we're going to be able to do all those things. It's going to take time. It's not going to look like what it looks like now for a while yet. But I do want to see, I don't want us to forget this. I don't want us to forget where we are and how we got here. And I think we need to double down and reinvest in public health infrastructure, because we've let that go. And we need to be better prepared for the next pandemic and the next public health emergency. We need more resources for public health.
And quickly, review.
I received the Johnson & Johnson vaccine a week ago Thursday. And this coming Thursday, I will be driving down to hug my mom. I haven't hugged her since before the pandemic began. And she also is vaccinated.
I have a 98-year-old aunt that I've not seen in a year and a half, and I am fully vaccinated. And after I see her, maybe I'll catch a ball game with Assemblyman Wood. I do think we need to, though, take the lessons from this pandemic and really apply them to how we spend every healthcare dollar in the state and in the country. And as Assemblyman Wood said, we really need to see how prevention, public health, healthcare delivery are really an integrated effort on behalf of our populations, so that we can begin to take down the systemic challenges that we've had as we've tried to confront this COVID-19 pandemic.
Well, thank you for being here today, to the three panelists, and thank you for watching this. Thank you to the Public Policy Institute of California for hosting this. Thank you so much.